Dr. Zaslav, thank you for joining us tonight on the Sports Medicine Research Rundown. Dr. Zaslav is director of the Center for Regenerative Orthopedic Medicine at Lenox Hill Hospital. He's also a professor of orthopedic surgery at the Zucker School of Medicine, Hofstra University at Northwell Health. He's the past chair of the Biological Association and the past president of the International Cartilage Repair and Joint Preservation Society. We are totally honored to have a pioneer in cartilage restoration on our podcast tonight. Thank you, Dr. Zaslav, for joining us.
Thank you for the kind introduction. I'm happy to be here. I like all your guys, and I'm very impressed with your group always. So, Tim, I appreciate your interest in research, and I appreciate the way you make it easy for people to understand.
Yeah, thank you very much. Can you make it easy for us to understand cartilage defects and how you classify them? Like, is there a certain system that you use? I always heard of the Outerbridge classification. Maybe that's outdated now. What do you do now, Dr. Zaslav?
Well, I think, most of the classifications I care about are ones that help me understand how to treat things. And I think the first thing to know is that articular cartilage is, this perfect smooth surface. And once it starts to break down, the chondrocytes are releasing enzymes, and sometimes you can have a very small or seemingly very small articular cartilage injury, and then over time, without any new injury, it slowly enlarges as the enzymes start to cause chondrolysis. And then, of course, you can get wear and tear on the other surface, so you start to get opposing lesions from the friction on this side. So it's not uncommon that, for instance, after an ACL injury, you may scope someone and see no cartilage injury grossly, and yet there is some microscopic damage to the cells, and a year later they're presenting with catching and locking and pain and swelling, and then you get an MRI, and all of a sudden, without a new injury, there's a large chondral defect. So that's the first thing to know. And I guess the way I look at it is it partial thickness or full thickness? And Outerbridge is, a system to look at that. But, I just want to know, is it partial thickness or full thickness? And if it's full thickness cartilage, does it also involve the subchondral bone? And those are the ways we make our decisions, really. Is it just a partial thickness chondromalacia or softening, or partial thickness delamination? And then we might just do something as simple as debridement. But once you start getting the articular cartilage fully injured down to bone by itself, prima facie, it doesn't heal itself. It has no attempt. If we break bone cells, new bone cells will form. And when you cut the skin to make an incision, obviously new skin cells form and will heal. But chondrocytes are somewhat protected, and they do not migrate normally. And so when you have a loss of articular cartilage, it usually not only doesn't improve itself or heal itself, it starts to progress, as we just discussed a moment ago. So really, once you have full thickness loss, you have to start thinking of some way, if you're symptomatic, to address new cartilage growth or some type of growth to fill this defect so you don't have a rut in the road. And once you have bony involvement, then you really have to think of involving healing the subchondral bone as well as the cartilage. So that may be a long answer to your simple question, but
no, that's good. That's really How do people get those ruts in the road, though? Is it an insidious onset? Is it a trauma? Does it just happen with old age?
All of the above. So I'd say, obviously in the younger patients, it's often related to a shearing stress trauma like ACL injury or some other type of shear or direct blow like landing on your kneecap and smacking the trochlear groove and causing chondrolysis there. So it can be traumatic. More commonly, it's related to malalignment. People have slight varus or valgus or patella malalignment that causes uneven wear and progressive chondrolysis in that area of uneven wear. It can come from being overweight. And of course, it can come from repetitive injury. Articular cartilage is a very unique structure that can rebound from trauma. So as it absorbs load, it will coil. And as long as that load is released and you rest, it goes back to its normal shape and its normal three-dimensional structure. But if you have repetitive load, like somebody like Kobe Bryant, who's playing 29,000 minutes of basketball over a career, that constant load doesn't give the cartilage a chance to really rebound. And so you start getting breakdown. So it can happen through repetitive overload, through overweight malalignment, or through a acute traumatic shear.
Right. That's interesting because one of the non-operative physical therapy techniques that we use is repetitive load, whether it be a bike or a load on a leg press that has someone doing the leg press through the full range of motion through where that defect is at a controlled load that isn't too painful but isn't pain free. That might be beneficial, and that's kind of the philosophy we use.
Well, I think that's reasonable because first of all, cyclic loading, of course, is very different than the type of shear load we talk about when you have a pivoting
Hmm.
maneuver or jumping. So cyclic loading, I think, is very healthy for cartilage. So I think that's a very good idea. And of course, when you're applying direct load like a leg press, you're doing that to build the muscle, and then that's helping to stabilize the joint and prevent shear. So all of that makes sense, I think. And it's really the repetitive pivoting, jumping, cutting, and high impact load that causes the problem.
Right, and those are in fact symptoms, I think, of an articular cartilage defect is joint pain and swelling and stiffness in the knee and some of that catching, maybe symptoms of that.
Yeah, it may be as simple as just swelling after activity, but all of those symptoms, really any knee injury can cause very similar symptoms here. And so when we hear a story, we think about, meniscus, we think about ligament, think about articular cartilage, and then it's really through the physical exam and ultimately MRI that helps us diagnose and focus in on the cartilage portion.
The physical exam, is there a special test for a articular cartilage defect, sort of like a Lockman's for ACL or something like that?
No,
Or
I wish there was. I mean, basically, the patients are tender at the joint line where the lesion is, but of course, that differential diagnosis is common with meniscus as well. But with the meniscus, there are specific tests. So if you have tenderness and swelling and stiffness, but you don't have a McMurray test and you don't have a Steinman test, then you might think, okay, maybe it's not meniscus, maybe it's more likely articular cartilage. But again, ultimately, it would be if the X-rays are normal and you have those type of symptoms, it's really the MRI that's going to give you the detail as to whether it's meniscal or articular cartilage or something else.
Great. Is there any like cluster of signs and symptoms that the patient reports that really keys you off to say, hey, you know what? This is sounding more and more like an articular cartilage defect.
Well, I think it's more about like a diagnosis of exclusion. So if you check all the ligaments and they're fairly normal, or if it's clearly just an ACL and you know that,
Yeah.
and you also have ruled out meniscal tear and you have these symptoms, then you start thinking, okay, this could be chondral. But in my own opinion, if you tend to have more bone pain and more just load pain, but not less mechanical symptoms, that often points me to say, okay, this may be articular cartilage rather than a typical meniscus.
Is articular cartilage pain a different type of knee pain in your experience? Like, does it radiate down into the tibia, or is it just basic knee pain? I have no idea.
Well, truthfully, cartilage doesn't have any nerve endings. So the cartilage,
Right.
so like a partial thickness cartilage injury, unless it's causing synovitis or a flap that's mechanically locking, that won't cause any pain. It's really the pain fibers are all in the bone. So we start to get pain when you start to have subchondral bone edema because the cartilage is not doing its job effectively to stress shear the bone below. And then you start to get pain really from the bone, is my own opinion. So it's
Okay.
sort of deep ache, similar to, a subchondral stress fracture type pain.
Right. Uh,
We would say grade threes and fours only, really, in that sense, right? If you were on your thinking process.
Only threes and fours is correct. Yeah, the twos and ones, we're scoping patients regularly for meniscus and ligament and patella fat pad issues, and we see significant partial thickness injury all over, and patients often don't even know they have it and they don't feel it. I think it's really the bone. When the bone starts to get involved is when we get pain.
right.
The bone doesn't have to have a defect in it yet, the bone just can be seeing increased load because you're not getting the load sharing from the cartilage.
Right. And the MRI is the best test to pick this up?
The MRI is the only real test to pick it up.
You don't need contrast anymore?
Not for these. No, you don't need contrast in MRI for the knee. The 1.5 Tesla scanners, if you do fat saturated echo techniques, you get beautiful look at the cartilage now, and certainly with a 3T scanner, 3 Tesla scanner, even better look at the cartilage. And if you want to know a little bit more, not only of the anatomy of the cartilage, but the function of the cartilage, you can do these new T2 mapping sequences, which most MRI computers have now on 1.5 and 3 Tesla. And with this mapping, you're basically look at prostaglandin function. So you're actually seeing earlier cartilage damage or early cartilage healing based on how well the prostaglandin function is going at the subchondral bone and cartilage junction. So all of that now can be seen, but really articular cartilage is pretty well delineated on a good standard fat sat MRI.
Gotcha. And the treatment for this non-operatively involves physical therapy, as we talked about, weight loss, supplements, maybe injections, PRP, stem cells. Have you had any luck with those? Can you speak to any of those? What's your experience with any or all of those, Dr. Zaslav?
Well, let me first say that it depends on where the lesion is and the size, right? So if it's in a patellofemoral region, I would say a very gigantic portion of patients with trochlear defects can be controlled effectively with quad core and glute progressive resistance strengthening that just helps to stabilize that patella within the quad so that it's not shimmying and not shearing across the trochlea. So we have great results with patellofemoral lesions with rehab.
Okay.
So I think that's it. Of course, weight loss helps everything in the knee. So every pound you lose is 4 pounds less force across the patella and the trochleus, and as well as the femoral condyles. So we always talk about weight loss, but of course, many of our patients are fit already. Supplements, I think it's a mixed bag. Certainly, one way to help control inflammation without having to live on NSAIDs is to take glucosamine and chondroitin. It's been helpful in about 80% of my patients. I don't think I've ever seen any healing or reversal of any lesions with supplements. But there's some data in animal studies that those 2 supplements may slow the progressive wear, but not probably reverse it. Injections, again, also are the best to bring the homeostasis back to the knee milieu. So all of these patients will have significant cytokine and metalloproteinase release as the cartilage breaks down, which is inflammatory and causes more breakdown. So if you can mitigate that by the use of cortisone or hyaluronic acid or platelet-rich plasma, that can be very, very effective in mitigating symptoms. And maybe with something like PRP, you can slow the progressive wear. But again, we've never seen healing of these lesions through injectables at this time. Stem cells, I think, is just a misnomer. We don't have any true mesenchymal stem cell treatments in the United States that are legal. People advertise things as stem cells, but they're really not. To do that, you'd have to take the cells from the marrow or the marrow or the fat, or you could take a few from the blood, and then you'd have to grow them in a lab and bring the patient back for injection once you've proved their stem by looking for certain markers, and you then have expanded them and got more of those stem cells and injected them in. That's not legal to do in the United States. So in the United States, what we're doing is orthobiologic injections, which include platelet-rich plasma, micronized fat, or bone marrow aspirate concentrate, where you take these things and minimally manipulate them while the patient's still in the office, and immediately within that hour, use them in the patient. So those are not stem cell products. There may be some mesenchymal stem cells in them, but you can't really say that because you're not checking that and proving it. So, but it does, I'm not sure it matters, because we know from Arnie Kaplan's work, the man who actually discovered the mesenchymal stem cell, that stem cells, when taken out of the body, grown and even put back in, even in the countries where you can do that, they don't act as stem cells. They don't turn into stem. They don't become something. They bring a little pharmacy, a little pharmacopoeia of growth factors, mRNAs, cytokines that are anti-inflammatory and pro-growth, and help teach your cells what to do. And then they're gone in days. So they're not stem in that sense. They're not turning into something. That's the patients think they're getting something that grows into something. It's not really the case. So you can get stem cell treatment, cultured stem cells in Barcelona and Panama and Chile and in some countries in Asia and in other parts of Spain, but they're not legal here. So, but I think the orthobiologics can go a long way to mitigating inflammation and swelling and pain and can last quite a while, 6 to 12 months. But again, we don't have evidence that they heal cartilage defects.
Right. But we do have ways to do surgery and repair cartilage defects. I've seen in my practice, certainly I rehab people with microfractures, mosaicplasties, ACIs, and most recently press-fit allografts. But all those that's hyaline cartilage that comes back, or that's articular cartilage that comes back in those surgeries, sir?
Well, of course, it's all very different. So it depends. Microfracture, it was the original treatment started by Stedman and others in the, and even pretty early in the 40s, where you're stimulating the marrow cells in the bone, the MSCs to come out of the subchondral bone and fill the defect with a cartilage-like substance, but it's fibrocartilage. So you can get the defect filled. It can look pretty smooth.
Mm-hmm.
It doesn't stand up to wear because it's very disorganized fibrocartilage. So usually they do well for 2 to 4 years, and then they start to deteriorate over time.
Okay.
So for very small defects where you don't have a lot of load on them, it's still reasonable. But most of us in the cartilage world don't do as much microfracture anymore. Now, osteochondral autograft and osteochondral press-fit allografts, that's taking whole pieces of bone and cartilage, which is pure hyaline cartilage already, and putting it into the defect. The mosaic plasty is mostly out of favor because in between the multiple pieces of cartilage and bone you put in, you get fibrocartilage fill.
Right.
So even the person who, Dr. Haggerty in Eastern Europe, who really masterminded that treatment and published the most on it, he'll do one if it's a very small defect, putting in a single small autograft or two, he'll do. But more than two, he doesn't do anymore because it's not as effective as some of the other treatments.
Okay.
But a single 1 or 2 plugs can be very effective and can get you very quickly back because you just need to have bone-to-bone healing, and then you have pure hyaline cartilage already formed from the same patient. And the same thing when you use cold-stored allografts. So this is a fresh allograft taken from a patient who dies, donates his heart and lungs, which are used within 24 hours. The knee is stored in a cold serum and stored for up to 20 days. You can maintain the cartilage. 85% of the cells stay alive over that 20 to 25 days. During that time, the banks can rule out any type of viral or bacterial infection. Obviously, they don't have time to do that on a heart or lung, but it's great that you can do that for these. And then you can schedule this case and take a whole large piece or two of articular cartilage and bone and press fit it into a defect you make where the defect is in the condyle, and you take it from the same port in the donor knee that you have at the side of the table.
Yeah, because it's curved. So how do you get the curve to fit,
Well, it's a little easier in the femoral condyles than it is in the trochlea because of
Right.
that the topography of the trochlea, but it's doable. And you take it from the same area. You try to match the size condyle to the human that you're working on. You send their MRI to the bone bank, and they look for one that matches. And when you have it, you do like a 10, 15-day notice, and then you can schedule your case, or 20 days sometimes. And then we have very, very good banks now that do a great job of harvesting these, keeping them sterile and getting them to you in time. So that's less of a problem in the United States. Now in Europe, there are very few centers that actually do allografts because they don't keep cartilage and bone allografts for some reason in Europe. It's very hard to get. So not very common there, but very common in the United States. And those treatments have really long data. We have Bill Bugbee, of course, at Scripps Clinic, who's a very good friend of mine, has been publishing on these allografts now, cold stored allografts for decades. He has 20-year data and, very good data that lasts, up to 10 years, and then 10 to 20, he still has 75% success rate, that maintains over very long periods of time. So that's been very, very successful. And as long as there's some issues, they're not cheap. The condyles cost about $13,000, but it's very successful. And again, that treatment allows the athlete to get back to activities in 6 to 8 months because you're just hoping for the good bone-to-bone healing and rehab, and then you can let them load because the articular cartilage is fully mature.
Mm-hmm.
On the other hand, autologous chondrocyte implantation, which is excellent treatment, and again, we have over 20. I did my first one in 1996, so that's a long time ago. So we have many, many years of data on ACI as well. But there you're taking the patient's own chondrocytes from a biopsy you take arthroscopically, and you are then sending it to a lab in Boston where they can take 4 weeks to clone 8 million cells for you and send them back now on a type 1-3 collagen patch. It's not really ACI anymore, it's MACI, M-A-C-I, matrix autologous chondrocytes. So much easier to do the surgery now. You can glue that patch in with fibrin glue. You might put in a couple of sutures. You don't have to put in a lot like the old days. And that will eventually, those chondroblasts that are your immature chondroblasts that they've regrown will now grow into pure hyaline-like cartilage. It's pretty close to hyaline. It doesn't have the same three-dimensional structure, but on light microscopy, it looks exactly like hyaline cartilage. And that's been very successful. The difference is it's a little longer downtime. You're still off crutches in 8 weeks, but you are not back to sports usually for at least a year, and it could be as far as 15 months in larger lesions because the autologous cells have to grow into cartilage. And if you think about if you've had an infant or a baby in your life and you touch their fontanelle, which is cartilage, when they're born, till they're about 9 months old, that's very soft up there. So it really takes time for new cartilage to become solid and to be able to withstand load. And so the same thing with this cartilage we put in, it takes almost 15 months to fully mature. By a year, it's fairly mature and strong, and everybody's a little different. So we don't start anyone running with high impact activity till a year after MACI, and we usually, some athletes we tell it could take a year and a half. So for a very competitive college or high school or elite athlete, you might think of the allograft because you can get them back a bit quicker.
Okay.
The ACI is nice because you don't have any concerns about disease transmission. It's your own cells. You don't have any.
But it's 2 surgeries.
Yeah, but the first one's just a quick scope. Yes, but
Okay.
big surgery. You go and harvest a little cell. You're off crutches in less than a week, and just waiting for the cells to be ready.
Gotcha.
So yes, one of the downsides is the 2 surgeries, and it's very expensive. So like I said, the condyle was $15,000 to $13,000. The ACI to get back to the United States is $50,000, the cells. So they're very expensive, but very, very effective and are covered by most insurance plans, both of these treatments now, and have been for over a decade. So these are the things we've been using for years, and they're successful. But as you realize, there's not an infinite amount of donor tissue for allografts. They're expensive. And there's a small chance of some type of very minimal bone-to-bone, occasional, maybe 20% of patients can have a very minor type of immunoreaction that doesn't allow the bone to heal. Pretty rare, but it can happen. And then, of course, again, you have to wait for the graft till it's available. You have to wait till you find a match, and then you suddenly have to do the case within 2 to 3 weeks. So those are some of the downsides there. The ACI, as I said, very expensive. And so we started looking at alternative single-stage procedures that might cost less and be as effective. And that's how I got into the research that we'll talk about next, I gather.
Yes. So that's you came up with the Agili-C.
Well, I didn't come up with it.
Okay.
There was a young guy from Israel. His name was Nir Altshuler. He was a engineer who studied at the Ben Gurion University in Beersheba, and he then became an analyst for a company that did M&A with big biotech, and he started to think about something that he might want to start. And he came to myself about 15 years ago. He met me at a ICR's meeting in Miami,
Mm-hmm.
and, maybe 16 now, actually. And I went to dinner with him and Andy Levy from New Jersey, who had met him once in Israel, and Elizabeth Cohn from the Rizzoli Institute in Italy. And the three of us sat at dinner while he pitched this idea of using sea coral, that is, using aragonite, coral from the sea, to stimulate bone and cartilage healing. So we listened a bit because there is a history of coral being used in spine fusion for bone. If you look at the electron microscope of coral and you look at the electron microscope of bone, they look almost identical. One is hydroxyapatite, the bone, one's aragonite, the coral, but on the EM, they look exactly the same. And they have the same kind of interdigital vascularization. And if you think about it, coral is a unique organism in the sea that takes elements from the ocean and turns it into an exoskeleton that we call coral. And then it flowers and it becomes the coral that people look at. But the dead coral is basically an exoskeleton. So we knew that if you take that and you put it in bone defects, it would cause bone growth. But people had tried to make cartilage, and all they ever got was fibrocartilage. At the same time, Nir noticed two papers, one by Rocky Twan in the United States and one by an Israeli researcher at his university, that showed that if you take human mesenchymal stem cells in a petri dish in the lab and you put those cells in a tube of a certain diameter, that tube, the pressure exerted by that tube will cause the MSCs to turn into chondrocytes and make hyaline cartilage rather than turning into bone cells or anything else. So his idea was, what if we took the aragonite and modified it so that the top third of the implant has little holes of this particular diameter drilled in it? Could we stimulate your own body's MSCs to become hyaline cartilage? So we said, it's a great idea, but there's a lot of work you're going to have to do. And over 15 years, that work was done. It was a very scientific company. And we were on the two of us, Elizabeth and myself, were the chief science officers in Europe and the US. And we began with goats and did multiple different types of drill holes, and eventually found the perfect group of holes in the right diameter and the right pattern that got really, really nice, perfect subchondral bone and perfect hyaline-looking cartilage. And we would send these biopsies off to an independent lab in Europe called NAMSA, and they would read it as hyaline cartilage. And
Wow.
the cartilage was perfectly adhered to the subchondral bone. So this organism, the dead coral, would stimulate your own MSCs to rush towards it and form bone. And then the cells that, as the MSCs hit those little tubes, they would turn into chondrocytes. But interestingly enough, in addition to that, we found that the Agili-C was philic for chondrocytes as well. Remember, I told you that when you break articular cartilage, the cells don't migrate and refill. But when you put this implant in, the cells will actually migrate from the periphery where the good cartilage is and go into the top of that implant and start to turn into cartilage.
What caused that, do you think?
I wish we knew. It's the magic of Carl. And we didn't believe it at first, so we did a study at Rush Institute in Chicago with a scientist named Susan Jumanskaya. She took dead patients who died the day before. They donated their knee. She took cartilage from their knee, cut a donut hole in it, put the implant in it, put it in the serum that we store allografts in.
Yeah.
Over 70 days, this acellular implant attached to a dead person's cartilage the cells would grow in and start making hyaline cartilage, type 2 cartilage. It's quite amazing.
That's insane.
So that's why we were very, very excited. So once we finished doing like several hundred of the goats, we did a first in man around 2015. And he was a cyclist in Slovenia. A lot easier to begin a first in man procedure in the Eastern Europe countries where the FDA is a little laxer. And this guy could not compete for 5 years due to a chondral defect in his medial femoral condyle. He put in 2 implants. Not we, I mean, the Slovenian surgeon put in 2 implants. And within a year, this guy was back competing. And he recently came in for a meniscus tear to that same surgeon almost, I guess it's 11 years later now. And the cartilage still looks quite amazing. And so does his MRI. So it's been very, very durable. So once that first in man was studied, they got a CE mark for Europe, and they were able to start using it at 6 and 7 centers throughout Europe. And both in Belgium, Italy, and Eastern Europe, they did over 126 more implants in patients first who had just focal defects. But then the Eastern European docs started using it in patients who had arthritis. So remember, all of these other treatments we use when they have a pretty normal X-ray, but a big defect in the cartilage, what we call a focal defect.
Mm-hmm.
And we've moved some of this into the early arthritic phase, but that's off-label from the FDA's use. This Agili-C, the data started looking so good in these patients with arthritis that when we did the United States study, which we'll talk about in a moment, we included half of the patients had focal defects with normal X-rays, half had KL2, Kellgren-Lawrence 2 and Kellgren-Lawrence 3. So that's joint narrowing up to 50, 60%, but not fully bone on bone. So no KL4 patients were included, but KL2 and 3 were included in half the patients. And that was the first study the FDA ever allowed arthritic patients to be in. And you'll see the results in a little bit. And we were just very, very impressed with the work that the Europeans did. So we started this multi-center study in the 2000s, and we started doing that both in US and Europe, comparing taking patients with focal defects and patients with multiple defects with arthritis on X-ray and putting in anywhere from 1 to 5 implants, covering defects anywhere from 1.5 centimeters up to 7 centimeters squared. That's a lot of real estate in the knee, 7 centimeters squared. You could have lesions in the trochlea, the medial lateral condyle, and do all of those. And we studied these patients. 50% of them had focal defects, meaning like the kind of studies most cartilage studies had, where normal looking X-ray, but a defect of any size. And then the other half were arthritic patients who had focal defects as well. And we followed all of these patients for 2 years and then 4 years. We had 96% retention in the study. So it was a very, very well done study. 96% of the patients stayed through the 4-year mark. And we compared on the focal defects, we compared it to microfracture, which is what the FDA wanted us to compare it with, which they considered the gold standard. And then for the arthritic patients, microfracture has never been proved to be successful. So we compared it with an arthroscopic debridement chondroplasty. And when we did the comparison, the data was quite remarkable. We ended up with a very statistically significant improvement in the KOOS scores by 6 months, and even more statistically significant at 2 years when you compared the Agili-C to the standard of surgical care. And whether that was in patients with focal defects or patients with KL2 and 3 arthritis, or when we separated the patients by lesion size, less than 3 centimeters squared or more, in every one of those groups, those separate groups, Agili-C performed with a KOOS score of 2 times as good as the standard of surgical care, microfracture or debridement. So very, very statistically significant. More importantly, when we decided to do preordained at the time of designing the study, we said, you know, we're going to call a responder rate a patient who has a 30-point improvement in KOOS. That's who we're going to call a responder. And so, by the way, minimal clinical difference in a COOS is 10. And we made sure that we said these patients have to be 30 to be considered a responder. 80% of our patients or 79%, I guess exactly, of the patients at 4 years were responders in the Agili-C group, and only 34% in the standard of surgical care. So very, very big statistically significant difference in those patients. And the 2-year patients were doing well. We followed them 4 years, and 2 or 3% more got into that group. So over time, they were not deteriorating like the old microfracture patients, but were actually improving, whereas the microfracture patients were getting worse.
Right.
So that's the story, and now it's been approved by the FDA and for about 1.5 years, and now Smith & Nephew has bought it, and so it's commercially available. So patients, we're now training surgeons throughout the country to do this procedure. The nice thing is, unlike the cost of the allograft at $13,000 and of the Macy at $55,000, even though this is as successful, its cost is up to 5 implants for $6,000 to $8,000. So cheaper and as good. And it's an off-the-shelf product. It doesn't have to be stored frozen or doesn't have to be stored cold. You don't have to try to find a match. You have 7 and 10 millimeter implants, and you can put multiple implants in. And based on the studies I told you before, the cartilage will migrate in between. So they fill in defects throughout.
Unbelievable. I can't wait till it becomes mainstream all throughout, not only our country, but the world. It's going to be a game changer, I think.
Well, I think right now in Europe, there's very few, there's almost none of the European countries except England, their health systems won't pay for ACI anymore, not because it doesn't work, but just because it's so expensive. So they said they just will go to a total knee, which costs less, which of course is not as effective for a young patient or for an active patient. So they don't have the option of ACI, and most of the countries don't have allografts. So this is really, really a major improvement in the European space and in Israel. And then in the US, I think it's going to take a little more time because we have other options, but I think it'll start to become much more popular.
Can I ask you one question about the failures that you had? The failures there was no significant difference in the failures between the groups. But there were 18 failures in the microfracture group, and then there were 12 in the Agili-C group.
So first of all, just remember that the Agili-C group, it was a 2-to-1 randomization. So there were 167 patients that got the implant and 84 that had the debridement chondroplasty. So
you challenged my research today when I was reading this article again to go over what a Goldilocks is. Okay, so and that's what it is. You got a bias 2-to-1 for a Goldilocks power analysis.
So this was 2-to-1, and when we looked at it, basically there were 7% failures in the Agili-C, but failure was determined very, very strictly. So failure wasn't removal of implant. We only had 4% of patients who had the implant that needed one removed. Failure also included if you needed a cortisone or an HA or a PRP injection or any intervention, arthroscopic surgery, injection, even a cortisone injection was considered a failure. So with very strict criteria, we had only 7%, and actually the other group had 21% failure.
Yeah, that's what it's showing, which was very interesting. There were some side effects which you get in any articular cartilage surgery, swelling and post-op pain and things of that sort of nature. But once again, they were not different between the group.
And that was what was so atypical, looking at multiple ages, anywhere from 20 to 70, looking at multiple size defects.
Yeah, it's great.
Those with and without arthritis, this implant was successful versus the other treatment in every one of those separate, post-op groups.
This surgery is done through a small incision, correct?
It's done through an open surgery. We're not doing it arthroscopically yet. And it's done through an incision. It depends on the size of the lesion. If you have a patient with a small focal lesion, you can do it under a couple of centimeter incision medially or laterally. you have a person that has patella, and I mean, you have trochlear defects and condyle, you may do a large incision like you would do for, you know, an osteochondral allograft or a total knee, because you have to have better ability to see all the way to the back of the knee or the front.
Okay. You put it only in trochleas and femoral condyles. Is there any chance that down the road you'll put it in the retrosurface of a patella in a focal defect, or what's your thoughts there, sir?
It's a very good question. We haven't done it in the patella for two reasons. The patella, especially in women, it's thin. So these implants are exactly 10 millimeters deep. So if you penetrate through the other side of the patella, you might end up getting tenocytes. Remember, I said this stuff, this aragonite is philic for all kinds of cells, MSCs, chondrocytes, but probably also for tenocytes. So you don't want synovial cells or tendon cells getting in there, because they won't turn into anything good. And so you don't want to penetrate that size. So we might have to make smaller implants. And I'm not sure how that press fit would work, but that's one of the issues. Number two is just that the cartilage is harder to match in the patella. So, you know, we haven't done it for those two reasons, but I'm sure someone will start, you know, over time as we do more and more, just like we did with Macy. It wasn't first done on the patella, but we, you know, expanded to it over time. But right now it's not approved. It's approved for all defects in the femoral condyle.
And the rehabilitation was pretty standard. You're on crutches for 4 weeks. You wean off the crutches at 6 weeks and progress to weight bearing. You start with general isometrics and progress to isotonic exercises, but you don't let them do any really active exercise for 6 months. And then
we don't let them do any sports or high impact exercise.
Right.
You know, we're very, my own opinion is we never want to see the glutes and the, you know, we don't want to get dynamic valgus. We don't want to have glute wasting. So we start very quickly on glute rehab and leg lifts and abductions. And then we start on, and they can be doing leg press, and they can be doing hamstrings after they get off the crutches. All of that's okay. Cyclic loading is certainly encouraged early on, and upper body work, everything is okay. Eventually you can move towards elliptical still, but we don't allow them to move. We haven't been allowing them to move to the high impact of cutting sports and everything till a year in the study. But my guess is probably like the allograft, we might find that at 6 months we can do that. We don't have that. That was not in the study, so I can't really recommend it yet.
Right. My thought is just to avoid shear if I got one of these patients.
Yeah, you want to avoid shear, especially in the trochlear patella region. So in the patella family, you want to join shear. You want to avoid shear, which of course occurs with open chain knee extension to some extent. And then, but with the femoral condyles, you know, you can push open chain as much as you want, and BFR and all those things, and just avoid the heavy impact of running. The other thing that's interesting about this implant is we put it in inset a bit. Remember, we said the stuff will grow in and out from it. And it's a brittle substance, aragonite, so you don't want it to be proud. So you want it to be a millimeter or two below the cartilage surface when you put it in, and then, so basically it's not seeing a lot of load stress in that exact area. So with a single implant, you're probably not seeing a lot of load there. But when you have multiple implants, you might be seeing a bit more, just because the real estate involved is larger.
What's the largest defect you think you can do? You think you can do a 10 or 15 millimeter defect with it, or no? With multiple implants?
What, millimeter?
Yeah.
Well, 10 millimeters, one implant. 15 millimeters easily. So we can do up to 7 centimeters, 70 millimeters with multiple implants. Yeah.
Okay.
The study included patients up to 7 centimeters. That's a lot of, that's usually 3 condyles worth of stuff.
Sorry. Yeah, I got it was centimeters. I got my metrics wrong. Okay. How about questions? Rob, Donis, do you have any questions? I don't have any more questions. Maybe we have some for the audience, possibly.
Yeah, there are a couple, but actually you kept answering, and as I was thinking, you answered it. So thank you. But how about, are we looking for the future, like the talus, the top of the talus, or anything in the hip? Like, what's the next?
No, it's a
progression.
Excellent question. In Eastern Europe, where they started with this, they've already published in the Foot and Ankle Journal talus. OCD of the talus, very, very effective. And what it's really great for, because there's no other good thing for it, is lesions in the great toe. So in the metatarsal head, those lesions are hard to treat. There was that Cartiva that came out for a while, but they all failed later. And they've done a number. They've already published in one of the European international journals multiple patients with these first ray lesions, and you put a single implant in there and you can get really beautiful bone and cartilage back and function rather than fusing that first ray or doing some type of implant. So I think that the next in the United States, I expect the first group to start to use it above and beyond knee off label will be the foot and ankle guys, both in the first ray and as also in the ankle. And then I think there's no reason it wouldn't work in the hip. We don't have any data in the hip yet, but again, the difference in the hip is you'd have to do a very big disarticulating surgery to get to it. So it's a lot bigger deal to do it. But for ABN, it may be an option.
How about your borderline cases? Do you look at biomarkers? So you got like the potential, like you have something starting to grade 2, you look at specific biomarkers that think, hey, you might get potential for you to develop further, or you don't kind of?
Well, we're looking at that. There's like 1 million biomarkers, and nobody's been able to purely isolate the right one that matters for osteoarthritis, although the work is being done. So Christian Latterman at Harvard, who's a great guy and a really smart researcher, has been looking at biomarkers that look at ACL patients at the time of ACL, young athletes, and take their synovial fluid and look at what's in it and see if they can predict who's going to have, OA down the road. And he did do one study, which was quite impressive, actually. If you look at cytokine analysis in a patient who's had an ACL at 2 to 3 weeks, they have tons of cytokines released that are inflammatory and starting to cause cartilage, negative behavior, and it's a bad neighborhood for cartilage and that stuff. But if you take the patient and tap the knee and inject cortisone in quickly, you can mitigate that whole reaction and they don't get the cytokine release. Unfortunately, when you do the ACL reconstruction, they get another cytokine release, and nobody wants to put cortisone in post-op to avoid infection. But so, we don't have all the answers yet, but probably, I'm a believer that treating the synovial milieu is just as important. So trying to mitigate those cytokine releases with hyaluronic acid or PRP is probably a helpful thing to do. But more research to come on that. But biomarkers are certainly important. And it would be nice to know that if you see this marker, that's a chondral bruise that's going to go on to an arthritis, and, we need to intervene. But we don't have that level of specificity yet.
Interesting. I have one more question, unless somebody else. But so MRI versus a scope. Do you trust the MRI enough, or you rather see a scope?
I do staging scopes very often. Because the MRI often underestimates the size of the lesion and sometimes the depth. The MRI is actually a little better for seeing how much bone involvement there is, in addition to the cartilage, because it can see the signal in the subchondral bone that you might not notice if you're looking at it grossly. But very commonly, I'll do a staging scope to see, is this defect really viable for, especially in the arthritic patients, is it just diffuse OA everywhere, and whatever I put in is going to wear out too because it's genetically predisposed to do it? Or is this a defect that can work and not be too big or too small? So yeah, I think the arthroscopic view is the ultimate determinant, to tell you the truth.
Great, thank you.
Dr. Zaslav, if some of our physical therapists and clinicians out there want to send you patients, do you see people only in New York City, or do you have another office anywhere?
No, I'm only seeing people now at the Lenox Hill office at Meath on 64th Street or at Hudson Yards. So I'm also on the west side in the new Hudson Yards office that we just opened recently. So I'm only in New York. But I'm happy to see patients related to whether it's meniscus or cartilage or ACL or ligament or shoulders. I don't do total shoulders. I don't do any total replacements for joints of any kind. I only do joint preserving procedures and ligamentous and sports medicine procedures. So I do rotator cuff and obviously labrum and capsular surgeries as well, but no replacements. So I'm happy to see any of your patients with sports injuries, and truthfully, I do a lot of work with therapists because, probably 70% of my patients get better without surgery. As I've aged, I've learned many, many things from my therapists. And the first is that, a lot of them can do better than they can with surgery with non-operative treatment. I treat some ACL patients non-operatively. I treat meniscus patients non-operatively all the time first, unless they have a locked bucket handle meniscus or a root. Because I can't tell you how many patients I have that get a single cortisone injection to mitigate the inflammation. I get them into rehab and they do just fine. That doesn't heal the meniscus, but they become pain-free, and that's all they care about. So, I'm a big believer in rehab and non-op treatment as well. And of course, we mix in the biologics like bone marrow and fat and PRP, most commonly PRP.
Well, thank you so much.
Thank you.
You're a wealth of knowledge and an excellent clinician too. I know that for a fact. But
So it's a pleasure talking to you guys.